Thank you very much. We will go for the next presentation by Dr. Lipi, a case of aqueous misdirection syndrome.
Yeah, so much has already been talked on and it's almost 6. I think most of you want to go and see the beaches. So I will be quickly covering this. Case of aqueous misdirection syndrome, no financial disclosures, brief introduction. We hardly need this now. AMS or aqueous misdirection syndrome is a relatively uncommon cause of secondary angle closure glaucoma that occurs due to postulated anterior rotation of the ciliary body. Clinically, it presents as axial shallowing of the anterior chamber despite a patent PI with elevated IOP. Initial management is medical and atropine. In addition to medical treatment, NDR, laser halludotomy and capsulotomy are laser interventions. Surgical management is indicated in the event of failure of all these modalities. So case report, first presentation of a case, 68-year-old male who underwent uneventful bilateral small incision cataract surgery in the year 2020, presented with pain and DOV unilaterally in left eye in the year 2022. So after 2 years of cataract surgery, he presented with these features of malignant glaucoma, corneal edema, shallow anterior chamber, elevated IOP were noted. That was 42 to 44 millimeter of mercury. Pre-op axial length was almost normal in both eyes with intraocular lens implanted of plus 24 diopter. Left eye was treated medically with atropine and there's 3 glasses of AGMs. Within 1 week, IOP normalized and the chamber deepened. Corrected vision was 6/9. Fundus examination showed normal finding. At this time, patient was kept on one IOP lowering agent and atropine to mitigate against potential future IOP spikes. I don't have pics of the first presentation. The second presentation, patient returned after 1 year in February 2023 with similar picture. He had stopped using all medications for 7 to 8 months. I'm in a government college, so patients usually do this. They don't come for follow-up also until they have a problem. Aqueous suppressants and topical atropine with oral acetazolamide relieved the symptoms partially. Patient was advised retinal surgery. Patient refused this. And so on relative clearing of corneal edema, laser PI was done. After 3 days, posterior capsulotomy and anterior halludotomy was undertaken. Transpupillary NDR vitriolysis was performed to semi-dilated pupil. Aim of treatment was to perforate the hyaloid membrane and to allow the aqueous believed to be trapped in the vitreous to flow into the anterior chamber. This is the picture post NDR capsulotomy and halludotomy. We see a laser PI also in the pic. So after 1 week, vision in left eye was 6/9 with the spectacles. That's corrected vision was 6/9 and IOP almost normalized. Presently, patient is on single topical AGM and atropine since past 6 months. I believe to continue atropine for a long period or even lifelong. He reports no major symptoms on his last follow-up in August 2023. So this is a 6-month follow-up. So here is reported a case of aqueous misdirection syndrome that occurred unilaterally in a pseudophakic patient with no history of glaucoma or pseudoexfoliation, with 2 years delay time from cataract surgery. Anterior halludotomy and capsulotomy along with medical treatment proved to be an option for the patient. These are my references. So when I was at Arvind Eye Hospital, actually as a fellow, I had not seen many cases responding to this capsulohalludotomy, and ultimately because retina department, it was just next to us, so we sent most of our cases for retinal surgery. So this is a case which I thought I should note, take pics and present it. But that is well known as Vanita Madam and Sir has already told anterior capsulotomy, halludotomy is being done.
So technically this is a pure glaucoma department case.
No, I would like to highlight the fact that when a patient presents with what looks like aqueous misdirection, then one should make an attempt to do a PI because we don't know whether this is actually pupillary block or not. Simply because the diagnosis of aqueous misdirection cannot happen if there is no PI.
Right.
So the diagnosis of aqueous misdirection says that in the presence of patent PI, AC is shallow and IOP is raised.
Right.
So that I think is a very good point that you brought up.